All right. Well, I have an announcement or two to make before we get going. So our winners of our gamification, visiting the vendors, the clinicians who visited and getting the codes the fastest. Number one was Dr. Matthew Weeks, whose wife will be very excited that he won an iPad. If you don't want her to have it, just say that you picked it up somewhere. Okay. And we also have two phone stands with Bluetooth speakers for Dr. Alan Francis and then Emily Haramis. How do you say her last name? Haramis, I'm so sorry. Okay. All righty. And Teresa, can we have you come up here? Okay. So I don't know. This is yours. Thank you. I don't know if anyone really appreciates what Teresa does for this conference, right? Behind the scenes. She makes the rest of us look really, really, really good. As a president and a board member, I mean, we show up and do our things, but Teresa's the one that really is on the ground, making things happen. And I heard this from multiple speakers and everyone else. And so this is a small token of our gratitude. But thanks for all you've done.
Oh,
You're awesome,
thank you.
Teresa. Okay. For sure. Okay. Hey, am I making? Thank you. And Val is probably the best historian that our organization could want, right? He is awesome. Okay. In terms of our posters, the first place poster is, let me put my glasses on, sorry. Morgan Green, Penicillin Allergy Delabeling Project. Among the residents. Second place is poster 6, Rachel Haynes, of Reducing Preventable Adverse Effects from PPIs. It's awesome. And then the third place is poster 4, Savannah Cox, Improving Follow-Up on Abnormal Pap Smears for Patients at a Residency Clinic. Thanks for, again, all the work you guys have put into those posters. They're really amazing. In terms of our students, first place poster is poster 13 by Brinley Young. Tattoos is a risk factor for B-cell lymphoma, which is pretty cool. Okay. The second place is poster 9. Caden Wheeler, does lactic acid bacteria inhibit biofilm formation of methicillin-resistant Staph aureus? And then the third place poster is Burdette Remington. Oh, hey, Alex. Which is, I can't read this whole thing, but by the increased efficacy of sorafenib in hepatocellular carcinoma. So great job, all three of you students. And then for our three medical students, the first place poster is poster 24, Jacob Warner, investigating the metabolic effects of ultrasound-induced lipolysis. Second place is Amanda McKenna Larson, holistic management of glucose dysregulation mimicking autoimmunity. And the third place poster is poster 39, Sarah Nugo, prevention of melanoma growth and invasion by lipophilic vitamin B1 derivatives. And those are all just fantastic. So another round of applause for all of them. All righty. Well, I really look forward to hearing from Dr. Anderson. Dr. Anderson was the cardiologist of Barney Clark, the recipient of the first mechanical heart transplant. Dr. Anderson completed his undergraduate degree at the University of Utah, his medical degree at Harvard Medical School, his residency at Mass General Hospital, his internship at the National Institutes of Health, and fellowship at Stanford University. His board certifications include internal medicine, cardiovascular disease, and clinical cardiac electrophysiology. Pardon me. His current interests of note include the genetics of cardiovascular disease, biomarkers of coronary disease, advanced cardiovascular imaging, pharmacogenetics of cardiovascular disease therapies, and adverse reactions, antiarrhythmic drugs, and clinical therapeutic trials. He is the brother of OSMS trustee Doug Anderson, who's also his hiking partner. And your other brother is retired, CEO of Zions Bank, right? Your parents must be so disappointed in all three of you. I think you've done some good things. So, and I learned also that Dr. Anderson is a world-class violist. Is that correct? But I look forward to hearing from him. There are some additional copies of the book just outside the door for those that are interested, that kind of mentions some of the story of Barney Clark. So with that, Dr. Anderson.
Well, thanks so much for the invitation to join you. And after all of that very nice introduction, my main claim to fame is to be Doug's brother, as you know. So he's a great friend as well. This is going to be a lecture in Medical History 101, because we're going to go back to a particular event that happened now almost 43 years ago. So just for my interest, how many of you were in medical practice in 1982? Okay, well, that's a fair number, but still there are a lot of hands didn't go up. And so maybe we'll bring to recollection, or at least to your attention, what I think was a very important event, not so much for what the artificial heart represents today, but really as a proof of principle that you can help sustain the circulation with mechanical circulatory support. So this was a very interesting case report, if you will, that garnered so much attention as one particular case that it became, I believe, probably the most attended medical event, publicized medical event in Utah medical history. It's certainly up there in the top 2 or 3, and led to, I think, a whole new industry of how can we mechanically help support the heart. So let's get into this a little bit and see if this might be of some interest to you. These are my disclosures from research studies we're still involved in, mainly in cardiovascular prevention, and none of them have to do with the theme today. So at the time, I was a junior member of the faculty at the University of Utah and Intermountain Health, and the vice president for health sciences at the university was Chase Peterson. Maybe many of you will remember him. So this was a letter to all of us as University of Utah faculty, and it's dated November 30th, 1982. Bulletin to all University Medical Center employees: the first FDA-approved artificial heart implant in a human is tentatively scheduled for Tuesday or Thursday, December 2nd, 1982 at University Medical Center. And then he goes on to just indicate that this will be under Dr. DeVries, William DeVries, Bill DeVries, we knew him as Bill, who had been approved to go ahead with this first implant, and indicated that there were quite a few people there from around the world, actually, not only in the U.S., for publicity, the PR people to be involved with this event. And if you happen to see somebody shuffling around the halls of the medical center looking lost, then direct them here or there to where we're set up to handle the press. So that was on November 30th. And then if you woke up on December 2nd, 1982, and got out the Tribune to read, this was a headline: Utah artificial heart pumping life through Seattle dentist. And they have a picture there of Barney Clark and a big picture of the operating room where this occurred. Just as an insight, I was a physician to Barney Clark. I had a heart failure clinic, and we had tried the best we could to keep his heart going for the past 9 months. And I actually was away prior to this at a medical event. I don't know where. All I remember is that I got a message that this event was going to happen that evening on December 1st into the 2nd. And if I wanted to be involved, I better get up there as soon as the plane landed. And so it did, and it landed in a big snowstorm. I mean, it was the kind of storms that we don't have anymore. That was before the impact of global warming. There was about a foot or foot and a half of snow in the valley. And so I got a taxi. We didn't have Uber in those days. That didn't have four-wheel drive, and we had a heck of a time getting up to the University Medical Center, but I finally made it. Just as they were wheeling Barney Clark in the operating room. And so I quickly scrubbed in and joined them in the operating suite. You'll hear about what my role was in just a minute. Don't be underwhelmed, but you'll hear about it. So let's start with a brief history of the artificial heart development. The first artificial heart replacement occurred in animals was performed at the Cleveland Clinic by doctors Kutsu and Kolf in 1957 on a dog that survived for about 90 minutes. Now, Dr. Kolf was a refugee from war-torn Netherlands, and he would come from Cleveland Clinic to University of Utah a few years later, and was sort of our senior investigator involved with artificial organs development. And so from this beginning, several centers designed and implemented artificial heart implantation experiments, principally in calves and sheep. Survival for up to 9 months was achieved in calves given the Jarvik 7 model Utah heart. And here is where really most of the work on artificial organs occurred. And so we were far ahead of the other programs by that time. Now, Denton Cooley, who was in Texas, used an orthotopically placed cardiac prosthesis as an interim measure before homograft transplantation as early as 1969, and again 12 years later. And these hearts function as intermediator devices for 64 hours in the first case, 54 hours in the second, and then they found a heart to transplant these patients. Unfortunately, this was in the very early days of heart transplantation. We didn't have a good handle on immunosuppression, and those patients died shortly thereafter. Now, the Utah program, the total artificial heart program, was developed over a period of 20 years or more, really, I think almost 25 years if you count the first time that Dr. Kolf was involved, before it petitioned and then was granted permission to proceed to implantation in humans. So that, by the way, of background. And now I have to give credit to Mike Talene, who's here today from representing the University of Utah Medical Library that provided me with, they have a rich supply of information from that event, that era. And this came from the clinical symposium that was written up by Dr. DeVries and his assistant, Dr. Lyle Joyce, a couple of years, well, actually the year after 1983, and it was illustrated by, in my era, the foremost medical illustrator, Dr. Frank Netter. I don't know if any of the rest of you love Dr. Netter, but you'll see some of his beautiful illustrations in the next few slides. So this is the cover showing the artificial heart going in. Okay, so let's look at that. So early artificial heart models, and there's a drawing of Dr. Kolf. He was the inventor of the artificial kidney, dialysis pioneer in development of the artificial heart. I can remember as a student at the University of Utah going to some of his lecture symposia talking about his work on the kidney, the artificial kidney, if you will, kidney dialysis as we now know it, which was really stimulating the time that I attended in the 1960s. And then down below, the functional model was made of silicone rubber produced by Kolff and Associates in the mid-1960s, about that time. Blood was pumped by intermittent compression of polyurethane sacs. So that was a principle on which the further development occurred, as we'll see with the Jarvik hearts. And so then things moved over time to actual application in animals. And I don't know if any of you have been to the old St. Mark's Hospital in North Salt Lake, but that's where, as St. Mark's moved, they turned that facility into this animal laboratory for testing of the artificial hearts as they were developed from one generation to the next, one version to the next. And this was primarily under Don Olson, who's the author of this book that you'll be able to pick up if you'd like. And he was a major player in the development of the heart. So the Jarvik set 5 and 7 hearts shown here were experimentally implanted in many animals. At first, calves were used because their weight approximated that of humans. The problem is that they grew very quickly and rapidly outgrew their hearts within a few months. And so sheep were used, and this is a sheep that was named Ted E. Bear. And he did very well. He survived for 10 months, which was a record, and he died suddenly when a heart valve broke. Otherwise, he would have just kept going for who knows how long. But here's Teddy Bear as was pictured back there in the early 1980s. And here's one of the calves, and he's exercising. And so they wanted to see, first of all, they wanted to keep these animals in good shape physically. They also wanted to see how the artificial hearts would respond to exercise. And so here he is on a treadmill, which occurred several times weekly for exercise, and then they would assess the physiologic responses during exercise with various versions of the artificial heart. And of course, they wanted to also develop a small portable driver on a battery that you could take animals and then later humans outside and just have something strapped over your shoulder and go outside for exercise and other activities. Okay, so here are some of the early artificial heart models. One of several models is shown here was developed by Dr. Clifford Van Gett, who was a major contributor in the development of the artificial heart. And this was one of he used pneumatically driven diaphragms to pump blood. And this heart kept a calf alive for 2 weeks in 1972. So that was 10 years before. And then down below and on the right, this was a heart developed by Dr. Leota, who worked with Denton Cooley. And this was a model that was actually implanted into a human in 1969 and operated for 64 hours as a bridge to transplant for that patient. Unfortunately, the patient didn't do well with his transplanted heart and died 32 hours later. So here's a picture of a youthful Robert Jarvik, whose name was assigned to the artificial heart. He graduated from the University of Utah, began working with this program, and I think went directly full-time work after graduation from medical school there. And so he went through various versions of Jarvik 1 up through Jarvik 7, which eventually was implanted in Dr. Clark, and you can see his Jarvik 3 heart pictured here, and then other models came thereafter. And this used a multi-layer diaphragms of biomer, which is segmented polyurethane, and they found that this was less likely to rupture. So you have to think about how long are these things going going to last, and that was the kind of diaphragm that was used in the Jarvik 7 heart as well. So let's just look at this illustration of the natural heart on the top and compare it to the artificial heart, the Jarvik artificial heart. And you can see up here on the left, the superior vena cava, right atrium, pulmonary artery, right ventricle, inferior vena cava, left atrium, aorta, left ventricle, and then sort of similarly here, these are the great vessel attachments. This opening from the right atrium, pulmonary artery, right ventricle, and the connecting tubes to the pneumatic drive system, opening from the left atrium, aorta, aspiration ports for removing air and priming the ventricles in the left ventricle. And then in the middle were Velcro patches so that you could just snap these together and you'd have a whole system operating. And so here a little bit about the function of the artificial ventricles. On the left, you can see in diastole, so the heart is filling both on the left and right sides. Blood comes in from the atria, goes out from the aorta, pulmonary arteries, in diastole, and then in systole, the pneumatic driver pushes air into this chamber and ejects blood, and the mitral and tricuspid valves are closed. And then with exercise, you probably remember the old Frank Starling relationship from medical school. The more that comes in, the more that goes out, and it accommodates that. So here with exercise, there's a greater inflow and then greater flow out during ejection during systole. Okay, so that's the very simple principle, and it's based on how the human heart's, that is, it's pulsatile. And we'll talk about how today we actually use continuous flow devices. But at that time, the idea was to mimic the human heart in terms of a pulsatile mechanism. So there was quite a large driver system here. Let's see. Console to which the heart here was attached through these driver ports, and you can see the different functions. And then here's the impact compact unit that Dr. DeVries is testing out, so patients could go outside with that on and have enough battery power for 4 hours and then come back in and get recharged. So let's talk about the Jarvik 7 model. Clinical use of this, again, occurred over a period of about 20 years of experimental development. It consists of 2 approximately spherical ventricles with anatomic transitions to the great vessels and atria. Each ventricle is pneumatically powered. Air is intermittently pulsed through the air chambers, and the rates can be adjusted from 40 to 120, physiologic range for most of us. The ventricles are constructed of smooth blood surface made of segmented polyurethane. Each ventricle has a stroke volume of 100 ml. The valves used in this were tilting disc, clinical grade, pyrolytic carbon prostheses, the Bjork-Shiley valves at the time. And then connections were made to the natural atria by cuffs made of Dacron felt, and these were connected to the artificial heart by a system consisting of rigid segments that you could just snap these on and very, very efficiently. All right, so enough of mechanics and of the valve. Let's talk about Dr. Clark and his experience. He was a 61-year-old retired dentist, was admitted for progressive heart failure, class 4, and he had extreme shortness of breath, fatigability that began 6 years before admission at age 55. And it was initially attributed to COPD because he was a former smoker, 40-packer. Today it's hard to put ourselves back in that era, but smoking was extremely prevalent. In fact, when I began practice at LDS Hospital, I remember I was up on the 4th floor in the cardiac unit, and I was a little pod of four offices, all cardiologists. And of the 4, I was one of the 4. The other 3 were all smokers, and they all smoked in their office. So I suffered secondhand smoke inhalation by going to LDS Hospital every day. That's the situation back in those days. And similarly in restaurants and airplanes, there wasn't such a thing as really no smoking. You're lucky if you were in an area where it was a little less smoke than in the other area. So that was not uncommon. And Dr. Clark was part of that era and part of that scenario. And so he had COPD. And in fact, both his age, being over 60, which was a limit for transplant at the time, and also his COPD were contraindications to a heart transplant. We weren't doing that at the University of Utah. They were doing it at Stanford, where I trained, but the closest one to us was in Arizona. So he was, we checked with them at Arizona. He was not a candidate, so we were left with no other options for advanced therapy. So it was 2.5 years before his admission. He's in Seattle. Severe heart failure occurred with low output in association with atrial fibrillation with rapid ventricular response. And treatment, it's interesting to think back what we were doing that many years ago, included diuretics, digoxin, long-acting nitrates, hydralazine, warfarin, and the echo showed a very dilated ventricle, 7 centimeters. That's big. If it's over 6 or 6.5, that's really large. And systolic function was grossly depressed. And so then he had recurrent heart failure a year later, and a year and a half before his final admission. You can see his blood pressure there was low, heart rate was high, pulmonary pressures were high, capillary wedge pressure was high, cardiac index was low. Normal is 3, his was half that. And he also had bursts of ventricular tachycardia, which make you very nervous. That's a prelude to ventricular fibrillation, which, as you know, is a fatal arrhythmia. And his ejection fraction was 23%, with normal being over 50. So coronary angiography was performed, and he had a 50% lesion in the LAD and otherwise clean. And these were not findings that could explain his cardiomyopathy. So because of heart failure, he was referred to me. He had some ties in Salt Lake City. That's where he was from originally. And so they decided to move here because it looked like he was really getting towards the end of the road. And so we tried some, at that point, investigational therapies. It's amazing how far we've come from that in heart failure treatment. And this was 8 months before admission. We tried a drug called amrinone, which is a positive inotrope. That was the thing in that era, is let's little push the heart with new drugs, amrinone, milrinone, and so forth. It didn't work for him, and it hasn't worked for others either. So we've sort of given up on that today. But we did a heart biopsy, and it showed some at least mild inflammation, myocarditis, and so he was given a course of immunosuppressant therapy with prednisone and azathioprine, and he did have some clinical improvement, and a biopsy a month later showed a decrease in these inflammatory cells, and then 3 months before admission, he was doing pretty well. He was able to walk about a mile on level ground in a slow pace, and even attended one of the Utah football games, which was great. But 2 months before that, clinical deterioration again occurred, and 6 weeks before, he was rehospitalized with low output failure, and he was given intravenous dobutamine, intensive diuretic therapy, resulted in only small improvement, and he remained in functional class 4. He was not a candidate, as I mentioned, for heart transplant because of age and COPD, and so I contacted Dr. DeVries about the stage of the total artificial heart program. Now, I need to tell you a little bit how that contact occurred. I think it's sort of fun. I just finished a workout at the old Einar Nielsen Field House. That's just north of the football stadium there. And so I slipped into the hot tub, to just sort of relax. And sure enough, Dr. DeVries happened to slip in about the same time. And so we were there in the hot tub, and I said, well, Bill, how's your heart transplant program, total life heart program coming along? Where are you these days? He said, Jeff, we just got approval to implant a total artificial heart in an appropriate patient. Do you have any patients that might be candidates? I said, well, there's this dentist from Seattle that I've been taking care of. He's a great guy. He's really medically knowledgeable, and he seems to be amenable to, investigational therapies, but he's going downhill. I don't think I have anything more to offer him. And Bill said, well, could I contact him? Sure, I think that'd be great. And so sort of the rest is history, if you will, but it all started in the hot tub there, Einar Nielsen Field House. So he contacted the Clarks, and Barney and his wife, Uniloy, went to the animal facility, saw the animals with these hearts pumping. He got a full description of the program that was going on and the risks involved. And I think he really understood that this was really, a leap, if you will, of faith and a venture into unknown territory. So now we'll get back to what happened then. So he signed consent to be considered for this, and he was admitted. He was severely fatigued, he's short of breath, nauseous, increasing abdominal girth and weight gain of about 10 kilometers. Extremities were cool, pulses thready, ankle and pretubular edema were noted. ECG showed atrial fibrillation with low voltage, non-specific ST&T wave abnormalities. Chest X-ray showed cardiomegaly, had a moderately large right pleural effusion, pulmonary hypertension, and he was given intravenous diuretic furosemide combination with tolazone, but this was sort of our maximal regimen, minimal diuretic response. So again, intravenous dobutamine was given, but this had to be interrupted because of lots of ventricular arrhythmia, bursts of VT, and he even had a 30-second run of VT at a rate of 200 with loss of consciousness and had to be terminated by a chest thump. So you know that things are not going well, and death would seem to be imminent within a few hours to a couple of days. And so at that point in time, he was taking the OR for implantation. And you've heard what happened to me. I was just landing in the plane and trying to get through that major snowstorm to be present during that historic operation. So here's an illustration again by Frank Netter. And I think this is really true to form of how he looked as he was going the OR with advanced heart failure, marked cyanosis, edema, and ascites, and just really no other options. I'm sure he would have passed on if we hadn't intervened that night or within a day. So here's what happened during the operation, and this is a little bit of a case report for you, but I think an interesting one, at least historically. In the OR, anesthesia was induced with fentanyl and metacurine. And the chest was opened through a mid-sternal incision, placed on cardiopulmonary bypass. The heart was excised at the level of the right and left atria near the AV valves. So what happened to the heart? Okay, so here's Dr. Anderson's role in this whole occurred, and that is the heart was placed in a bowl and given to me. And so my job was to take that heart down the hall to pathology to Dr. Elizabeth Hammond, my good pathology friend who's still operating, played a major role in this, and try not to spill or stip it, to drop it. And then hustle back to the operating room. And connections to the great vessels were made with vascular grafts. The left and right artificial ventricles were installed and connected to the atrial grafts and great vessel grafts. Internal drive lines were tunneled subcutaneous to exit from the left flank and were connected to the drive lines of the pneumatic heart driver. The operation was complicated by increased tissue friability and hemorrhage and initial dysfunction of the prosthetic mitral valve, and they had to replace the left prosthetic heart because of that broken valve. However, that happened. Fortunately, it had a spare, and so they just took that one out, put a new one on. The patient readily came off bypass, stable hemodynamics, chest was closed, total pump time 4 hours, 9 minutes, operative time 7 hours. And so that was the operation. And here's just an illustration of what was done. Of course, as for virtually all open heart surgeries, a mid-sternal incision, and then the dotted line shows where the heart was excised, and the aortopulmonary artery and atria were incised as indicated, and the heart was enlarged and elevated here in this illustration, and ventricles were excised at the AV grooves. And so that's what it looked like prior to sending it to me to take to pathology. So a couple of operative views, illustrations of what was seen. So once the heart was gone, here's what appeared in the OR operative view, and the great vessels here, and the atria here, and then stitched to that were these Dacran graft segments with cuffs on the end that could be clipped onto the artificial valve. So those were sewed into place, these cuffs for the great vessels and atria, and then they could be snapped on to the artificial right and left ventricles. And here you see that happening. It was just snapped onto the atria and the great vessels on the left ventricle and right ventricle, and then they were snapped together or adhered to each other through those through the Velcro patches. And then the drive lines were brought out through the skin, as you can see, and they used these what we call skin buttons to reduce the risk of infection getting back here along the drive lines and improving safety of the procedure. So post-operative course. Patient opened his eyes, moved his extremities on command 3 hours after surgery. Extubated successfully. On the second post-operative day, was conscious, communicated with family and physicians. Cardiac output was adjusted to 7 liters per minute, index 3.2, perfect numbers. Aortic pressure, you can see 124/60, perfect. Left atrial mean pressure 12, PA pressure 36/20, right atrial pressure 12, all normal values. And in contrast to preoperative course, a brisk diuresis began to occur. Postoperative ECG showed electrical activity was absent, straight line. We'll get to that in a minute. And the radionuclide study showed that left and right ejection fractions were 69 and 62, perfectly normal, compared to 10% LVEF and 29% RVF preoperative. So a major change there. And so here you can see the preoperative ECG and blood pressure. Post-op, blood pressure went way up here. ECG went from here to straight line. I happened to be teaching some medical residents the next morning. I showed them a copy of the 12-lead EKG, which just showed flat line and all of these. And I said, what's the diagnosis? This is a real patient. This is a real EKG. And if you hadn't been reading the morning papers or were up to date, said, patient is dead, asystole. I said, no, his artificial heart. You have to get that in your mind now. So patient doing fine, artificial heart, no electrical signal. So that was sort of fun. So here's the classic picture, a painting from that picture of Dr. DeVries smiling, Barney Clark smiling on 2 days after surgery began. And then this is 2 weeks later, this is his wife, Una Loy, with her husband, and Barney sitting up and smiling and doing really well at this point in time. I might just mention that Una Loy was a great volunteer for the Heart Association. She took Barney's passing very well. She saw this as an important milestone in the development of mechanical support that he had contributed to, knowing the risk. And even though he later would pass along, she was a really a dynamic, energetic spokesperson that traveled throughout the country advocating for funding for research in heart-related issues and mechanical circulatory support. So this was what our pathology department, Dr. Hammond, found with the heart sample, the heart that I brought her, and you can see these areas of fibrosis and also these hypertrophied nuclei through the heart indicating a significant heart failure. And this is the x-ray. You can see the left and right ventricles postoperatively. Okay, so now we get to the tough part. The convalescence period was complicated. Roller coaster, get prepared for the roller coaster ride here. Thoracic exploration was required on day 3 because of subcutaneous emphysema. 2 ruptured right pulmonary blebs were identified and repaired, consequence of his COPD. On the 4th and 5th days, renal failure developed in the presence of postoperative hemoglobinuria and diuresis was initiated by increasing the cardiac output to 12 liters per minute, really just forcing blood through the kidneys. Unfortunately, this led to seizures occurred on day 6 in the setting of this high output as well as metabolic abnormalities, and it's just gradually improved over the next couple of weeks. On day 13, sudden left heart failure developed. In the OR, a fractured strut of the prosthetic mitral valve was found, and the left ventricle was had to be replaced, because the valve is part of that whole apparatus. Day 24, a fall in left heart filling pressure, sudden pulmonary hypertension were noted, resolved after 48 hours during continued anticoagulation and transient resumption of mechanical ventilation. We never found the cause of that, but maybe some kind of pulmonary embolism. And so this is just a picture of when they went back to the OR, they found this strut of the valve had broken, and the leaflet had fallen back on the diaphragm. And so they just replaced the whole left ventricle with valve included, and the function was fine thereafter. So by the 32nd day, patient nearly at dry weight, mechanical heart function was normal, and the patient's mental status was improving. Second month was notable for second bout of ATN that was attributed to the antibiotic amikacin, moderate pulmonary insufficiency consequent to coronary emphysema, decreased lung water, complications of anticoagulation with hemarthrosis and epistaxis. Again, roller coaster ride. Third month complicated by a third episode of renal insufficiency after amphotericin and a positive fungal culture, and by continued pulmonary insufficiency. But now, by the first day of the 4th month, patient's renal function had improved. Mental status was intact. In fact, he provided a taped interview from the press, which they loved. His physical therapy was progressing. His appetite had returned. His respiratory status had stabilized, and plans for eventual discharge were envisioned. Well, I wish we could stop there, because when I got that word, I was feeling really great. But, unfortunately, and here he is, exercising on a bicycle, standing, walking around, looking great, really looking just fine. She made it through all those things. However, on the 92nd day, diarrhea, projectile vomiting, resulting in aspiration pneumonia, blood cultures grew 3-gram negative organisms, respiratory support, parenteral nutrition were instituted, pneumonia and fever gradually resolved with broad-spectrum antibiotics. And then just 9 or 10 days later, rapidly progressed renal failure leading to anuria. Associated findings were hematochezia, fever, and hemodynamic instability. Sigmoidoscopic exam showed pseudomembranous colitis. Blood cultures were negative. Treatment with vancomycin was begun, but progressive circulatory shock consisting of refractory hypotension despite maintenance of cardiac output led to death on the 112th postoperative day. The postmortem examination revealed extensive pseudomembranous colitis, ATN, peritoneal and pleural effusions, and chronic emphysema. Microscopical loss of pontine and hippocampal neurons was observed. Artificial heart system was intact, well anchored by connective tissue, and uninvolved by thrombotic or non-infectious processes. So maybe an empiric victory, but not a clinical victory. Well, just here's sort of my concluding thought. So that was the case report. This experience with Dr. Barney Clark was a roller coaster affair, which ended with an unfortunate outcome for him personally. However, it really did represent an important proof of concept that months-long mechanical support of circulation and life-sustaining function could be achieved mechanically. Nobody had ever done this for more than 60 hours, and certainly not with the intent to be a destination therapy. And so he can be, I think, wholeheartedly honored as a true medical pioneer who showed the courage and sacrifice in the exploration of a new frontier in medical therapeutics. So now fast forwarding 42 plus years to today, mechanical support has evolved and progressed to small, continuous flow, centrifugal design left ventricular assist devices that can be used not only as a bridge to transplant, but also as to bridge to recovery or to destination therapy, potentially extending life from years to even decades. Well, this is the article that appeared in the New England Journal of Medicine, and it's one of the few major articles, sole articles that just dedicated to one particular patient, to one case report, this was dated February the 2nd, 1984. And you'll notice the authors here are Bill DeVries. This is myself, and I was lucky to be second because my role was to write the article, so I was the draftsman for this article. Lyle Joyce, who was the surgical assistant, Fred Anderson, who did a lot of the cardiology care afterwards, Elizabeth Hammond, who was a pathologist, Robert Jarvik, who designed the heart, and then William Kolff, of course, who was the father of the artificial heart as well as artificial kidney development and was still alive at that time and was recognized for that. But I think we should add to that, very importantly, Don Olson, DVM, and you've seen that this book of his that really will fill in all the gaps and wonderfully written, True Valor. Don was really an unheralded and critical element of the team. He was the one who really oversaw all of the animal experiments. He's the only one that had done dozens and dozens of surgery in animals. And of course, Bill had helped him on several of these, but he had the most experience. And so he was in the operating room. He couldn't actually do the surgery with his hands, but he provided invaluable throughout the surgery and complications, insight into where to cut next, where to sew next, and so forth, and was heavily involved in this program all the way through. So I'd recommend that highly. So after that experience, things were held up at Utah. There were big concerns about all these complications. Let's deal with those. What was he the suitable candidate with his emphysema? and so forth. And so Bill DeVries went to Louisville, Kentucky. They offered him a great deal and did several more, but never had the kind of success that he was hoping for without complications. And so from the total artificial heart, things evolved in a somewhat different direction for most of the mechanical support therapies that are now provided. Although a rare case worldwide of a total artificial heart is used primarily as a bridge to transplantation with right ventricular as well as left ventricular failure present, since if you have RV failure, the LVADs, left ventricular assist devices, aren't going to help with that. But this has moved through 3 generations, from the first generation to second and third. The first generation mimicking the total artificial heart in that they were pulsatile flow. They had valves, they had mechanical bearings, and they were large. You can see the typical first generation LVAD pictured there. It was FDA approved as a bridge to transplant in 1998 and as destination therapy in 2002. But outcomes were not ideal, and so the second generation came along, which were continuous flow. Forget about the pulsatility. They said we can still do well with continuous flow, but it had an axial design, and it had bearings with mechanical pivot and bearings with a stator. It was FDA approved as a bridge to transplant in 2008, destination therapy in 2010. And then building on that to the third generation, where we are right now, and this is being refined, which are continuous flow, but they're centrifugal design and non-contact bearing design, so magnetically driven without bearings, and bearingless, magnetic and hydrodynamic levitation, and the goals are miniaturization and durability, approved for bridge to transplant 2012, destination therapy 2018, and that's where we are currently. This is what it looks like. This is much smaller than the one that Barney Clark had. It doesn't do as much, but often it's adequate to augment heart function and maybe even allow the heart to recover. It's placed in the LV apex, as you can see here, and then the flow is directed here to the aorta continuously, and this is what it looks like on X-ray. And so those have been increasingly effective. So if we look at survival over time, here's the curve without treatment. This is sort of the Barney Clark untreated curve, and you can see everyone's gone within 12 months. First generation improved, sort of 12-month survival, about a third. Second generation, 12-month survival here for 50% over a year, and then third generation, even better, as you can see here. And this is a heart transplant. So getting closer and closer to heart transplant survival, and even closer now. So the device currently used is the HeartMate 3, and in this study called the Clear LVAD, it was compared to the HeartMate 2 and other LVADs, and you can see better design, and at 1 year there's about 90% survival, really pretty darn good with better durability. This is another study, Momentum 3, that showed superiority of these centrifugal flow pump LVADs compared to the axial flow, the Generation 2 LVADs. So that's where we're at right now. We're just fine-tuning the centrifugal flow pumps. Meanwhile, transplant has improved, and so the median survival has gone from about 8.5 years to 10.5 years, 12.5 years, and now, and more recent, you can see it's probably around 15 or so years duration, so really pretty impressive. After this experience, Utah began to explore setting up a heart transplant program. We didn't have one at the time of Barney Clark. I trained at Stanford with the heart transplant team there, that really had the first successful heart transplant program in the U.S. And we brought here to Utah, as I came to Utah, and we brought Jay Mason, Mike Bristow, and others. We set up a heart transplant program here, which began in 1985, 3 years later. And it's one of the world's most successful programs, 80% 5-year survival, 90% 1 year, and an equal number of women and men. And donor hearts are limited, though, this many in the U.S. And so a growing impact of these small booster LVADs for bridge to transplant destination therapy. It's wonderful to have both of these advanced therapeutic options. And in the heart failure guidelines, both of these are listed, both mechanical circulatory support and cardiac transplantation. Mechanical support, durable support, which is what we're talking about, is reasonable to prolong survival for carefully selected patients with advanced, we call it stage 2 heart failure with a reduced ejection fraction. And similarly, cardiac transplantation, evaluation for transplantation is indicated for carefully selected patients, again, with advanced heart failure, despite guideline-directed medical therapy, device, and surgical management. And this gets a grade 1, and this is a 2A, a little behind it, but both of them very important factors. So what about the pros and cons of these advanced therapies? Well, so the pros of transplant, better survival than the LVADs, although these are catching up. Fully implantable, improved quality of life and functional capacity, but cons are limited donor pool, need for frequent testing, graft rejection, immunosuppression, opportunist infection, coronary artery disease of transplantation, malignancy, and comorbidities. Here are the pros for VADs: improving survival, improved technology, less infection over time, rise in learning curve, and I might add, it's available, on the spot. You don't have to wait for an appropriate donor to come along. They're on the shelf, ready to go. Cons are still less durable than transplant. It requires power source, anticoagulation, external drive line, hospitalizations, infections, pump failure, thrombosis, and bleeding, strokes, arrhythmias, and right heart failure can be seen in some cases. So the promise of improved symptoms and survival, but trading one problem for the other. So it brings with it its own complications. So last slide, the key is really the right timing. Again, this is operative risk of death. This is worsening nutritional status. You don't want to do too early where they're going to survive on their own with medical therapy. But then in this period, you want to start thinking about it, because if you wait too long, the 1-year survival is much less. This is futile as compared to earlier, and that's where the art of medicine comes in. We have a superb heart failure team, and fortunately, we were able, when I was young in my career here, along with Jay Mason, Mike Bristow, and others, to combine the programs at the University of Utah, at Veterans Hospital, at Primary Children's, at Intermountain Medical Center, into one program called Utah, the Utah Transplant Affiliated Hospitals, so that anybody with heart failure that needs advanced therapies is reviewed by this combined committee, and decision made as to what is the best approach. Is it medical therapy? Is it a device? Is it transplant? Is it one followed by the other? And where should it be done? Who is best able to handle this patient, and in terms of insurance coverage and so forth. If we have a heart available, where should it go? Which patient should get it? So there's not competition, but there's cooperation among our major centers, and including, of course, anyone here in Ogden or elsewhere in this area. So we're very, very proud of this program of advanced therapies for heart failure that really dramatically impacted people, including people like Dr. Clark. And with that, I'll just thank you for paying attention and see if there are any questions.
this is not a question, and I've been kind of crying as I sit at the table over here, because Dr. DeVries is from Ogden. Just not too long, I don't remember exactly what year, after this surgery on Barney Clark was performed, Dr. DeVries spoke to this organization at this annual meeting. And today, hearing this follow-up, 40, whatever it is, 42 years or whatever,
That's
after that occasion, is just, to me, a great example of how we here have had an opportunity of seeing what has developed and occurred out of this earlier medical intervention. Thank you.
Thank you for that comment. Appreciate it. Yeah, we're very fortunate that this event, has just spurred continued interest in treating the patient with heart failure. And I think there's no better place in the country or the world, even today, to be treated for heart failure.
Thank you, Dr. Anderson, for coming
Okay,
and
you're
telling
welcome.
this amazing story. Correct me if I'm wrong, but I think another player in all this, that heart-lung bypass machine that Barney Clark was on was developed by Dr. Russell Nelson.
Yes.
As well. So there's another Utah connection.
I
Question.
agree completely. Thank
Yeah.
you.
Question for you is, was it ever thought that if Barney Clark did really well and recovered and went home, would he have ever been a candidate for a transplant at that point? Would that have changed the tide, or was that ever a thought or ever a discussion?
Good question. I don't think at the time he would have been, because they had fairly strict criteria for transplant. And I think both his age, but even more so, I think his advanced pulmonary disease, COPD, would have been contraindications. But under other circumstances, yes, I think that its best use would have been as a bridge to transplant. In other words, if it done well, and he otherwise would be a candidate, and somebody would have accepted them. And we're accepting, we have more and more lenient criteria these days for transplant. We know more about it and make it safer. That I think that's the major use of mechanical support. And even with these small LVADs, I think in most cases we first try to see if we can recover the heart, and we've done some of the most important work here at the University of Utah with that. And especially if you have non-ischemic cardiomyopathy, you're younger, you've had it for a shorter time, if you rest the heart for a certain period of time with an LVAD, you can actually take it out and the patients continue to do well without anything. The second use would be bridge to transplant. If you don't recover, then go on to transplant. And then finally, for some, it would be destination therapy. But I think that has to be carefully weighed against the age of the patient, his normal or expected survival, and so forth. But thanks for the question. Appreciate it.
Dr. Anderson, thank
Well,
you.
thank you very much.
Could I ask you another question?
Oh, yeah, sure.
Could I ask you two questions? There's actually a few more, but first off, thanks for being here. Incredible. My first question, you mentioned heart failure and the superb care that's given here in the Utah programs. This is clinical. Does altitude play into that at all? And the altitude we are at in Utah? But the more important question I would ask you is, would you comment just on the media or publicity that happened around the first artificial heart? I was a teenager in Indiana. I remember on a black and white TV seeing a little bit, and some of those memories are coming back. But would you comment about your interaction with the media?
Well, first of all, in terms of the altitude, I don't think that plays a huge role. Back in the days where we had limited medical therapy, one of the common treatments, in fact, and our grandmother was sent to lower altitude because you had better oxygenation. And so that might be a mild role, but we can usually compensate for that. Yes, the media coverage was incredible. And so we had a daily press conference And, you know, our vice president, Dr. Peterson, Chase Peterson, put on a white coat. I'm sure he hadn't worn it for quite a while. Got a stethoscope. I'm sure he had to go buy one. But every day he was out there, you know, in front of the mic for these hundreds of people from all over the world. It was just an incredible amount of interest in this. And again, it emphasized how groundbreaking this was. In my own case, my brother Scott, our brother Scott, was involved with Bank of America in Asian division, and he got a request from China that they wanted to hear about the artificial heart. Well, this was back in the communist days, and that's the last thing they needed. You know, they were a very poor country in the mid-1980s, and so he arranged for a tour of myself and a few of our team members. Dr. DeVries couldn't go, but we had Dr. Joyce, and went over and went to a series of cities in China and told them about the artificial heart. Again, the last thing they needed just basic medical care, but it just indicates how much interest there was in this worldwide. So.
Dr. Anderson?
Yes.
We first met when you came up to Billings, Montana
Yes.
in '89 or so, and you were lecturing on a new drug, Enconide, that I happened to be working for the company was making. And I found you're a very interesting speaker. You haven't lost a thing there. And I've enjoyed
Thank you.
I've enjoyed watching you as you play in the orchestra on Temple Square. It's always fun for me to say, that's Jeff Anderson. I know that guy. So a few years ago, they had a sci-fi movie about a person. They put in a pulseless heart device to someone and talked to, you know, and this was so outlandish to think about, you know, a centrifugal device. And as we've looked at this, I had a patient of mine who was on an LVAD for 2 years before she got a heart transplant. It was so fascinating to have no pulse. And yet she was very healthy and lots of, you know, problems that they had to address, but she's alive and well today, a couple of years post-transplant as well. Who came up with the idea of the centrifugal pump? And I guess they had to try it on animals to see if it was actually feasible.
Right. You know, I don't know the answer to that, but yeah, that was a big leap because it was felt that, you know, you had to have pulsatility. That's, you know, we evolved to expect pulsatility. But fortunately, we're able to do this, which is a much more durable device with these tiny devices. There are some disadvantages. You know, for example, the aortic valve doesn't have to open and close so much. It just continuous sort of says half open, you know, all the time. And sometimes you can develop aortic regurg, and you have problems that way. You have to get the valve replaced. And there's also problems with atherosclerosis because it's not used to that pulsatility in the blood vessels. But overall, the results have been surprisingly good that you can get by, at least for several years, without the pulsatility. That's a great comment, but thank you.
It's wonderful, thanks.
Okay, you're welcome.
Hi, Jeff. Bill Hamilton here. I remember this well. I was an anesthesia resident at the University of Utah at the time, and we in anesthesia often get ignored because the surgeons get all the glory. So I just wanted to mention that I think it was Dr. Nathan Pace
Yes.
who was the anesthesiologist. So
Thank you, and I completely agree. We need to give more credit, and I do as well. I'm guilty of that.
these cases can be hard on the
Oh, I'm
anesthesiologist.
sure. Thanks so much, Bill. Bill was the president of our medical association, Intermountain, and good to see you, Bill. Well, thank you very much. Oh, one more, okay.
What are the current criteria for transplant?
Well, you know, the current criteria, they tend to evolve over time, and they get sort of older and older. And I'm not on the transplant team, but I suspect that Barney Clark, in terms of age, could have qualified. I think at least up to 65, and maybe some cases to 70. You know, we're living longer, and we're in better shape. And you know, you do have to meet certain criteria in terms of overall health status. You know, they have to figure that if you have a good heart, you're still, you know, you're not going to be limited within a year or two of from other illnesses. And obviously, you have to be somebody that's going to take your medication, not going to forget your rejection medications, and you're not going to get hooked on drugs, because these transplants are very hard to come by. We're limited 2,000 a year nationwide. So I'll have to refer to our heart transplant team, but basically, and we're using hearts, donor hearts, that we wouldn't have used in the past. We know how to utilize them and match sort of older donors with older recipients. And so we're doing everything we can to maximize benefit to patients and treat more patients than we have before. Well, thanks so much. Appreciate it.